Good evening, everyone. It's Thursday, the 30th of June, 2022, and it's a program. It will be quite interesting program. But before we go into the program and before I introduce my guest, I just like to make a disclaimer. This is a live program. In a live program, we may say something or we may do something beyond our control. So therefore, the disclaimer is that if we say something, do something, it doesn't match up. It's a mistake. Please forgive us. We are a human being, and that's the fact of the life. And as I said, this program, if anyone want to ask a questions on the topic with my guest, by all means, you will need to ask the questions on my platform. It's on the Facebook Zones. Also, we are broadcasting on YouTube as well, Foot Medic. But I will share this program with many podiatry group. Hopefully, by sharing it, many podiatrists will have access to the program and they can ask questions as well. Also, if you want to ask any sort of questions within that topic, please do so, because it's not going to be long. It's going to be about half an hour program. Also depends on my guest, and also depends on how well this program is seen by other people. As I said, it's a good topic, and hopefully this topic would be good for every one of us. Right. So, by the way, before I start chatting too much myself, let me introduce to my guest, and he will introduce himself and his background and what we're doing currently. So, David, if you don't mind, if you can introduce yourself and background of you, and then the topic we're going to speak about today.
Hi, Samas. Thanks for the invite, first of all. I'm David Cashley, and I'm a podiatrist of 25 years, graduating from Queen Margaret University in Edinburgh. I've been a manual therapist for those full 25 years as well, starting my interest in manual therapy as soon as I left uni, where I opened my first clinic with my brother, who's a chiropractor. And so we worked as a team, both chiropractors and podiatrists, looking at lower limb injuries. And along that journey, basically, I picked their brains about how manual therapy works and what interventions are appropriate for various subjects. As I moved along, I developed an efficacy for treating Morton's neuroma. So I wrote a couple of brief papers on that, just initially a case study, because it was interesting that we'd had such a good effect on a condition that we don't normally treat particularly well. I think it would be fair to say that in the podiatric realm, Morton's neuroma success rates are not encouraging, whereas we were finding consistently good results. So we published, first of all, a case study just demonstrating what the technique was and how we used it. And we followed that up some years later with a clinical audit to say just how successful the treatment was proving to be. Of course, the challenge with that level of study is always that, there's no control and it's not gold standard. So just recently we followed that paper up with an RCT, and we have completed the RCT and written it up and submitted it to a journal. So hopefully any month now that should be published, and that demonstrates a huge efficacy of manipulation in the treatment of Morton's neuroma. In the meantime, we've also written a couple of other papers looking at ankle treatment and non-specific foot pain. So a few bits and pieces kicking around, but most of my time spent in clinic treating, and my personal clinic's almost exclusively manual therapy, and so that's the topic that floats my boat.
So absolutely. So my question will be, the first question will be, What are the myths on manual therapy?
So the biggest myth, so there are two big myths that I'd love to dispel.
Please
The
do.
first one was raised as a challenge by a paper by Hilton Menz, and way back in the 80s, and it was a fair challenge at the time. But he asked the question, is foot manipulation science or mesmerism? And his answer by the end of his paper was that it was mesmerism. And I can fully understand how he came to that conclusion. And I think it was a fair assessment of the science at the time. But the myth, I think, in that paper is that it's mesmerism. I think what was actually true is that science hadn't caught up with the reality of how effective manual therapy is. What I would say now is the science is actually pretty robust. And the science for not only that it works, but also how it works, it is really pretty good and getting stronger year on year. So that would be, yeah, go on.
Because as you know, manual therapy goes long way before any medical intervention. If you look at the history and the ancestral history, manual therapy was there, part of the treatment protocol or treatment regime in ancient time. But obviously in this modern time, it's all about a lot of research or evidence-based medicine and so on. So another question to you then, what are the effects on manual therapy? The effectiveness?
So there's some primary things. So that probably goes back to my second myth that I would like to dispel.
Please, by all means.
It's not, we're not treating a bone out of place. Okay, and this is a common discussion. We've had this so many times with pod surgeons and whatnot. And they talk about how can the cuboid be displaced in a plantar cuboid or whatever, and it's so well bound in there with that ligature. There's no way it could be physically displaced, and that's absolutely right. We're not putting an out of place bone back in place. That's absolutely not what we're doing. So that would be the second myth that I want to dispel. And that ties into the research of what we are actually doing. So there are a couple of really key pieces of research. So for example, Sparks in 2013 demonstrated that in response to manipulation, we have a decrease in cerebral activity in the areas of the brain that are associated with pain processing. So we know that what we're having is a very definite and very profound neurological effect. So that's issue number one, is that the effect is primarily neurological. But there's a second impact as well, which is also crucial, and that's in the mediation of inflammatory pain mediators. So in 2006, Ian Yan et al. Established that we see an immediate 20% reduction in inflammatory pain mediators in response to manipulation. 20% is a massive amount. That's a big kick down in the amount of pain modulation that's kicking around. So if we're dropping that immediately post manipulation, we can see that we have a neurological benefit. We also have a neurotransmitter benefit. On top of that, McPartland in 2005, his team showed a 168% increase in pain relieving hormone excretion immediately post manipulation. So we're having this huge analgesic effect, absolutely massive, and we're having it on a chemical level and a neurological level. So while we're having undoubtedly a biomechanical input, the stimulus is biomechanical, the results are not mechanical. So we're not looking for bones to sit better or joints to move better. They may do. The joint may well move better. We know that there are some changes to joint function immediately post manipulation. But that's not really what's happening. That's not the crux of it. The crux of what's happening is the neurological changes that occur. And we have some great research by a fantastic researcher called Dr. Heidi Havik. And her research looks at the plasticity of the brain in response to both central nervous system function and peripheral nervous system function after, pre and post manipulation. So for me, it's all about the neurology and the changes we make to it. Does that make sense?
Yes, because you put a lot of research into it, right? So there are many research, but there again, as you are well aware, the osteopath, the chiropractor, and the manual therapist, even physio, what are the 90% of their profession? Isn't this manual therapy itself?
Yeah, for sure. I mean, manual therapy, it's, you know, it spreads its arm far and wide. And like you said earlier, it's been around a long time. You can look back to the, you know, the ancient manuscripts of China before there was even a Western civilization was talking about manual therapy. You know, the Egyptian hieroglyphs have reference to manual therapy. You know, Hippocrates himself was a manual therapist. You know, so it has a long tradition, and that's fine, and that's good. But I think we're at an aging stage now where long traditions aren't enough. We need to back that up with science. So it is important that the science is being done.
Absolutely, without shadow of a doubt, because it gives a safer modality, and also it gives the outcome, because there could be a lot of unknown outcome, but with the science and clinical trial or clinical practice, those myths we can overcome, or we may retune or refine what we were missing, or what the modality or the simple word, the protocol. We may define the protocol for certain modality. For example, I'll give you an example, right? I'm sure we have all seen, you know, like when little bit of dislocation, either finger twisting. So when you go to the hospital, what they do, they put the dislocation back to its place, isn't it? Isn't that manual therapy? What do you think?
Absolutely, absolutely. And the thing is, we all, as podiatrists, have manual therapy in our toolbox. You know, I mean, every time you strap someone, every time you pad someone, it's manual therapy. You know, a lot of us are using kinesio tape, etc. now. Although there's a neurological component to that, it's manual therapy. But the nice thing about that is that we already have, as a profession, we're actually really very dexterous. And so those extra skills of mobilization and manipulation come to us really quite easily, you know, so we're in a good place to utilize these skills.
And like you said, practice makes perfect. Another questions I have for you, just define, or what is the difference between mobilization, manipulation, or manual therapy?
Okay, so manual therapy would be the umbrella term, the overarching term, which includes massage, mobilization, manipulation. You could argue it even includes exercise, rehab, strapping, padding. So it's an umbrella term for basically anything that's hands-on, really. When it comes to mobilization and manipulation, the key term, the key difference, I would say, is in where that movement stops and what it's trying to achieve. So with a mobilization, we will take the joint to its end range, so to its painful point, and come away from it again. And generally, as a rule of thumb, although not always the case, and certainly something like fascial manipulation would be a different ballgame altogether, but in the kind of traditional mobilization, you would repeat that process, coming into the movement and out, into the movement and out. But each time you take the joint just to its physiological barrier. So you're going to take it just to as far as it wants to go and no further. However, what manipulation does is it forces it a little bit further.
Yes.
So that rapid thrust at the end,
Rapid thrust, yes,
takes the joint beyond the physiological barrier and towards its anatomical barrier. And the nice thing about doing that, the important thing about doing that, is that the joint would never take itself into that space. So it's a kind of buffer zone at the end of movement where the joint knows if it goes into this space, it's being forced that way, and there's a risk of damage if it continues in that direction. And so it must set a cascade of corrective measures off in order to protect itself. And so manipulation uniquely sets that cascade in place. So pretty much what it does is it sets your fire alarm off. So alerts the body to the problem.
Basically, manual therapy is the mother term. And then within that manual therapy, it's like podiatrists. Both of you and me are podiatrists. Within our podiatry, we got speciality or specialism, like surgery, injection therapies, and many. As I said, I say as a podiatrist, we are unique. We got many modalities. God knows how many modalities we can, and it's increasing. And our scope of practice is also evolving. As the modern days of medicine is evolving, so is our scope of practice evolving. Same with like both of us, we do manual therapy, whether you want to call it mobilization or manual manipulation. The terminology differs, but the principle is the same. Don't you think so?
Yeah, absolutely. Absolutely.
Okay. Another question then. How do you think this manual therapy or mobilization is benefit, or how do you think would be an ideal concept to take in and enhance or increase within the podiatry perspective, basically lower limb?
Okay. So what we know is that the analgesic benefit of manipulation lasts from 24 to 72 hours, depending on what research you read. So, but you're looking at about a 3-day window of pain relief. And if you were to accept that that's the only benefit, no, I don't. I think there are many more benefits, but even let's assume that was the only benefit. What that does is it gives you a 3-day window where you can tell your patient, okay, you can exercise more aggressively here, you can ramp up your rehab, you can push on, you can use this pain-free period to really ramp up your therapeutic input. So it means that rehab exercise programs, etc., will be more effective. They will have their impact quicker because people can progress pain-free at a much faster rate.
David, we have a question or comment. Thank you, David Smith. The difference, or at least a convenient characterization between mobilization and manipulation, as I understand, it is low velocity, large displacement, high acceleration in short time versus high velocity, low displacement, right? Constant velocity over a relatively longer time.
Yeah, I mean, it's one aspect of what's going on. You can really get into the minutiae of that now and kind of look at lever arms and whatnot. Do we use a long lever arm to affect this manipulation, or a short lever arm with greater velocity? You can really get into the physics of what works best. But there was some interesting research actually on that line in 2013 by Nuga. And Nuga found that actually the greater the force applied, the greater the duration of the analgesia. And that's really interesting because that's kind of back to front.
That's like the opposite science. It's like biomechanics.
Yeah, it's really quite strange. So what this guy's saying is the more force you've put into the manipulation, the longer the analgesic effect. And that's really quite nice for someone like me, because I'm not the gentlest. I'm really quite
I know, like David, Mr. Cashley, okay.
Yeah. So this is nice to know that the magnitude of the pressure is directly related to the degree of analgesia. But there's lots of things to look at in there in terms of lever arms and forces and whatnot. And certainly within a half hour of a chat, we never get to the bottom of that. But suffice to say that the manipulation tends to be high velocity, or certainly the manipulations that I use will be high velocity, low amplitude.
Absolutely, because I was taught to a version of it. The mobilization version of it, gentle type, and then manipulation. I don't know if you know David Lintonborn. He's an osteopath, well-known osteopath. He lectures throughout the world, right? High volume, low thrust, right? Yeah. And with him as well, I also teach as an associate lecturer with him. And fantastic, when I do those courses, it actually improves my knowledge. Mm-hmm. And improves the technique, because there is not one fit everybody, and everybody differs. Even when we teach or taught many students, many podiatrists, or even other healthcare professionals, when they go, they develop their own technique, and they'll ring me up, hey, Somus, no, yours is, I found another way. I said, that's good. That's what they're learning in. It doesn't mean that this technique is absolute. No, everything evolves. Practice evolves, times evolves. And it doesn't mean that we don't refine things. It's just like any sort of treatment, drugs, surgical procedures, or technique. It will evolve naturally, or it may change naturally. Look at medicine sometime. Sometimes they will say, you can no longer use that medicine. There was a reason for it, but all this time we used it and it had a benefit. Suddenly somebody came with research that you can't use it.
Yeah, no, there's certainly a lot of room to play. For example, we know that within spinal manipulation, that because of the segmentation of the spinal complex.
By the way, I need to say, so this guy Hassanujaman, he is, I think, somewhere in Europe. Thank you. Okay.
Cool. Well, as long as he's enjoying it, that's good.
Yeah. Well, it's an education. Both of us are learning as well. We are convinced.
Yeah. So the nice thing about the most recent research in terms of spinal manipulation, and this hasn't been translated into the periphery yet, but there's no reason why it won't be, is we know that we don't even have to be that accurate. We know that when we deliver a thrust, the reverb of that thrust goes for some 5-6 centimeters around the area, and still will have that benefit, that therapeutic impact. So, even if you're one joint out, you're going to have an impact.
Our colleague David Smith, more force is difficult to define if you don't define the time element, because you need to understand the integral, especially when dealing with non-motion issues.
Sure, but these areas were very well covered in Nuga's paper in 2013, and it was a force v time curve that was examined. So, and what the significant finding was that an increase in magnitude with relevant with equal speed would produce a greater degree of analgesia. We can pop that. We can. I guess you do case notes on the. Do you do? Is there somewhere where I can put the paper up for people to read?
Yes, they can. They can ask you, or they can ask on, because I've shared this on many podiatry forums. I'm sure we can pass the information on, because remember, I believe in education. The only thing, as you know, I'll be open, because I don't care. I hate people dictating me what I cannot do, what I can do. I really get vexed on that. For a while, I'm sure you follow me. I don't like people dictating me what I cannot do, what I can do. I say it is individual practitioner's choice what they do, and it is up to them how they go see things. It is for their own benefit. Whether the education is formal, informal, it makes no difference. Education, even for 1 minute, is an education. That's how I see it, my friend.
Good.
We may differ, we may agree to disagree, but isn't that nice to agree to disagree?
Yeah, that works. So if anyone wants any of the papers I've mentioned, I'm more than happy to share them. So if they just fire me a message on Facebook, and
Absolutely.
I'll share them.
Another question I want to ask, I've seen lately, I don't know how long you've been teaching, you do as well teach manual therapy, right? How was the response from our podiatry groups?
Yeah, it's overwhelmingly favorable. Podiatrists tend to just get this, it just makes sense to a podiatrist because we look mechanically all the time. The kind of the idea that mechanical inputs have a neurological therapeutic benefit is, that's not new to us. That's exactly what an orthotic does. An orthotic doesn't structurally change that position, or rarely structurally changes that position, but it has a huge neurological impact. And, so we're really comfortable with that concept. So I find that anyone who does the courses tends to really grasp it very, very well.
But like, as I said, I've recently noticed you are doing, but when I was doing this course, mobilization course, there was one chap from Australia. He used to come to the UK. I forgot his name on top of my head. Yeah. He more or less pushed that quite high, right? Then there was, everything went a bit, flat out. That's when I went to a course with David Lintonborn. I approached him whether you can do it. He goes, look, there's a grading as well, because manipulation has a grading, level 5 grading or something like that. So we spoke to our insurance. They said they have no problem. They go, look, as a podiatrist, you're only doing a lot of invasive surgery. So for us to insure you that level, manipulation level, no problem whatsoever, right? So then we took the courses, and then, we've been doing the courses for the last 3 or 4 years. And most of the time, it's quite full up because, as I said, like you said about a few minutes ago, it's a hands-on skill we already have as a podiatrist, and it's enhance our skill. So what do you think in this perspective? There should be more courses on different modality for podiatrists or manipulation?
Well, it's a difficult one, isn't it? Because when it comes to kind of undergraduate level, there's only so much you can fit into a degree program, Yes. So I don't really see a place for it at undergrad. But postgraduate, I think that, the more the merrier. And I think Ian Linnane does a great series of mobilization courses, and I haven't yet done his fascial manipulation course, but I fully intend to do that. He's kindly invited me a couple of times, and I haven't been able to go. But the feedback I've heard about it has been quite phenomenal. The work that he leans on is by the Stecco family, and when you read their research, it really is quite mind-bending stuff. So there's huge scope.
This is what another philosophy I use: learn and earn. The more you learn, the more you earn, and you should learn. Instead of being very critical for everything, you should learn from all sectors. So you do mobilization manipulation. It's worth learning how you do it, or what is your theory behind. And then when I do it, you should come and learn, right? Instead of criticizing, you should learn, because learning is never ending, my friend. Mm-hmm. It doesn't end. It's everybody has a different technique, and everybody teaches differently. And mobilization, manipulation, manual therapy, if you look at it beyond our podiatrist, physiotherapist, chiropractor, and osteopath, they differs. But like you said, end of the day, they're doing one umbrella called manual therapy.
Yeah.
But their techniques are different. So what do you say on that respect?
Yeah, no, I think you're dead right. I think the more tools we have in our box, the better we are for our patients, and you can pick the most appropriate tool. If the only tool you've got is a hammer, then everything's going to have to be a nail, and that doesn't really work, does it?
No, so, it doesn't. So we are almost finishing our. I thought half an hour is enough for today. In future, if they want more, I'm sure they can approach me or approach David. Is there anything you want to say before we disappear for tonight?
Yeah, just thanks for the opportunity to share my experience, and if anyone has any interest in talking about manual therapy or coming on the courses or anything like that, then just drop me a message. I'd love to chat with you.
There you go. Whoever, what a podiatrist or non-podiatrist, healthcare professionals, whoever want to go and learn mobilization. But I assume you only do for the lower limb, or do you do it for full body?
No, I'm just lower limb.
Lower limb. Okay, I'm sorry. As a podiatrist, we are all lower limb, right?
Yeah.
So, but again, you need a couple of days solely on lower limb, so you'll get best out of the best, right? So anyway, David, it was a much pleasure to have you on my show or on my program. And like you said, education is the way forward. My friend David, again, anyways, David, was on your course that I first learned that definition. There you go. He's giving you the tablet, antibiotic, back to you.
He's a good guy, is David.
Yeah. Thank you, David.
If I remember him well. Yeah.
I know. Thank you anyway, and have a lovely evening. And everybody else, as I can say, disclaimer, if we have said something, it's a live show. Please forgive us. Don't take us as a face value. We are human beings. Mistake can be made. But anyway, lovely to see everybody who have watched our program. It will be there on YouTube or Facebook. Please see it, hear it, and learn it. Thank you, David, and good evening.
My pleasure. Thanks for listening. Take care.